antibiotics like caficidin. Okay, you can wash with permanganate potassium, or you may give erythromycin tablets or syrup, or chlorhexidine, or amoxicillin. Okay, or these agents just help to bacteria. Now, impetigo we have seen. We have two types, non-bullous and bullous. Okay, and the complication is that they may lead to sepsis or to 4Ss. Now, management, topical steroid. Please don't give steroid. It's topical antibiotic and associated if the regions are right. Just steroids have any role in the treatment of impetigo. Now, Candidiasis. Let's go back to impetigo was here. Now we go here. So this is a bacteria. Microorganism. Okay, it is invented looking at the skin. You have surface of the skin, which is it has odors. Okay, then which means the infection most of the time is at the upper dermis. The they need cellulitis. You see, this is a triangle. The base, the dermis, which means clear margins. Okay, but all of them erysipelas, it will lead to cellulitis. Okay, impetigo may go to here, but most of the time there is a port of entry. Reaction, Tinea may expose the skin, but then organism penetrates to make dermatitis in here. If we have not done erysipelas, this is just the evolution of the one. Understood? You go down to the fats, to the subcutis, okay, or to the muscles. Here is the muscles. This one progress into, if not treated, the eye. Okay, to fasciitis, fasciitis, severe. Okay, a shiny raised and tender region with distinct margin. It's tender, that's one, and it's warm. Okay, right is erythematous lesion that involve the dermis and epidermis, with borders which are not related or sharply demarcated, as seen in erysipelas. Okay, refer to the picture I have shown. Causes are this one. Systemic symptoms like fever, lesional lymphadenopathy, the lower limb or the lower limb may swell. Okay. Now, what do you think? Is it this? Is it erysipelas or psoriasis? Huh? And tender. Okay? But when you go here, the all limbs is swollen. Okay? The port of entry was here. Huh? The patient had eczema. Okay? Now, complication, there are superficial ulcerations, abscess, necrotizing fasciitis, lymphedema, the all limbs swell. Okay? Now, what investigation to do? You swab for culture and gram stain, but don't waste time to treat because it responds well to antibiotics which are available and affordable. Okay? Then when you have this, tender, warm, inflammation associated to fever or not, always you have to find a port of entry in psoriasis or erysipelas. If not, check the patient for immunosuppression. It may be AIDS, HIV, or diabetes. Because I have seen a patient who had necrotizing fasciitis of the hand involving the all limb because the patient, he was diabetic. Okay. The left thing hamaganani, shirgan pad more ferric. And you have to admit him. Then, if you know port of entry for the microorganism, then check for immunosuppression, especially HIV and diabetes. Okay? Management, we have many. Manage erythromycin, chlorhexidine, penve, amoxicillin. All this you may treat people, a patient with erysipelas or psoriasis. Okay? And I recommend always when you are in the setting like here, the patient have this, they will see within 1 or 2 days, he does not respond to the treatment, then refer the patient for further management. Okay? Then, because you have seen that erysipelas progress into psoriatis and psoriatis into necrotizing fasciitis. It's the same entity, the same disease, but the periods of the progress differ. Okay? Okay? It's short, but it contains everything. I think for further reading, you will go to your guidance of dermatology. It's clear. Okay? Is it clear?
Yes.
Yes.
Yeah.
No question? Okay. It's clear, no question. Mwihangane dukore topic ya nyuma turekeraho. Okay? Superficial fungal infection. which is also a good topic to cover. Na byinshi bibyo we take a break or we finish this topic, then we go. Ibutare, we continue or we stop here?
We finish the topic.
We finish.
You can continue on the
Okay.
Finish. Finish it first. Then you go.
Now, this is another interesting condition. Superficial fungal infection or fungal infection. We start by the first one, seborrheic dermatitis. The skin may be infected with yeast, the levain. Okay? Yeast are commonly present on the greasy skin, which are the face, the nasolabial folds around the nose, the scalp, or other seborrheic regions like the groin. But mainly, it will be the V-neck, I don't have mentioned here. It will be nasolabial folds. It will be the scalp. People who have seborrheic dermatitis in this area as a disease, they have fine or thin scales on the scalp. It's known as dandruff or imvuvu. Okay? But on the face, you have just slight discoloration, especially at the nasolabial fold, and it itches. Okay? The cause is the Malassezia genus. Everyone has it, but following some conditions, like in hot areas, like here, just people may be predisposed to have this because it's a saprophytic organism, microorganism. We live it with, but for some conditions, following some conditions like climate, hot regions, immunosuppressions like HIV, AIDS, diabetes, etc., then people may develop this one. But otherwise, everyone has it. Now, the cause of seborrheic dermatitis is the one is itching, dry or greasy diffuse scaling and crusted deficiency, and cradle cup. Cradle cup is like but made of crusts in severe cases, like in HIV. Of course, secondary infection and weeping dermatitis as complications. Look at this patient. I know this patient, greasy and thick scales on the scalp. This is a severe seborrheic dermatitis of the scalp, okay? In the end stage of HIV, AIDS, okay? It's ntabwo zikiri mu zindi zisanzwe, then birafasha, okay? This is seborrheic dermatitis. Investigation, none, because we have to to rule out it with clinical diagnosis. Okay? Treatment, topical antifungal, like miconazole nitrate cream or ketoconazole cream. We have plenty of antifungal topical treatment. Cotrimazole, okay? But like in this patient, you have to treat to associate the local treatment with systemic oral treatment. Okay? The oral treatment, you know which one? The other one we have here in our setting, fluconazole. Okay? Hariyo bita fluconazole n'imidazole yose. Itraconazole, ketoconazole, tablets. Then you can treat it from 15 to 30 days. Okay? But on the scalp, you may add as well a shampoo. Okay? Ketoconazole shampoo, they are available and cheap. Selsun shampoo. Okay? What to return in seborrheic dermatitis is that it's caused by Malassezia species, genus. Everyone, it's a saprophytic microorganism, which means everyone has it, but following some conditions, it may turn into a disease. And in immunosuppressed conditions, the disease becomes even severe. Okay? Treatment, local treatment, and systemic with antifungal treatment like fluconazole, the most common and known. Okay? Now, the second one, Candidiasis versicolor. Isse. Hapana so isse. Okay? It's common. Okay, in hot climates as well. Okay? And it's caused by, again, the Malassezia genus. Okay? You see, this Malassezia yeast may give different skin conditions. Seborrheic dermatitis, Candidiasis versicolor. It can even give what we call folliculitis Malassezia. It looks like acne. Okay? The difference with the acne, it itches. Okay? We said it's a part of normal skin flora and prevalent in hot and humid climates, environments. Sign, can we go ahead and today? Now. Okay. I think everyone has seen it. The clinical diagnosis is easy. Okay. And you can even adapt. When you adapt, you can just use your direct microscope using KOH 20%. It's easier to do it in OPD, for example. When you adapt, just look with direct microscope. Look at this gentleman, a profuse Candidiasis versicolor. How do you describe it? Oh, what's it? Brown. What brown now? Describe the regions. What do you see? Different from the normal skin. The normal skin is here, for example. But here, you can see there are plaque, there are patches, what are them? What do you see? Huh? White? Okay. Is it a plaque? Is it a patch? Are you sure? You can't palpate it. It's palpable. Then it's not a patch. Okay? Then if it is not a patch, what is it? It's a plaque like. Okay? They call it here to form a plaque. And with scale, it's scaling. Okay? A large plaque with fine or thin scaling. Okay? And it itches. Okay? Now, treatment is easy. Is pityriasis vesicular contagious or not? Who says contagious?
Not contagious.
Okay. Here in Gako, a half just support that it's contagious. The other half not contagious. How about Huye?
From what I heard it that it is contagious,
Is it
but
contagious or not contagious?
it is contagious.
Uh-huh. Who says not contagious? Huh?
In the
It's
slide,
not contagious because it's a part of normal skin flora. Okay? It's not contagious. Okay? Now treatment is easy. Antifungal. You may use topical. You may use oral treatment. And the one I favor, for me, I use topical treatment. Then take a shampoo, one of these ketoconazole, Selsun shampoos, to apply to shower with, use it as a soap every evening. Then just it stays. Then after 20 minutes, 15 to 20, then you wash out. 10 following days at least. Then you may use it because it is recurrent. There are some people who live in condition that they may have it recurrently. Then you may use this shampoo as preventive measures like once per week after the 10 days, successive days. Okay? Sawa sawa. Now, candidiasis. Again, this is another yeast infection. Candida albicans is always a problem when it's diagnosed. Okay? It's not a normal part of a normal skin flora. Okay? Which means we may have it in abused children. Of course, if you have a child who has candidiasis at home, just think about abuse, the abuse, sexual abuse. Okay? It's always a problem. Now, risk factor, local factor like skin maceration, tissue damages, endocrine disease, diabetes. You have seen that diabetes always it goes together with HIV. This diabetes is a debilitating disease. It's even more debilitating compared to AIDS. Yeah. Okay. Because HIV and AIDS, you can prevent it if you want. Okay. Yes. But diabetes, no. Slightly, because we have these genetic conditions that predispose people to have diabetes. Secondly, once you have it, treatment is always tough. Any mistakes, then you may have problems. AIDS, okay, if you were disciplined, always you may have it, but continue the normal life. Isn't it? Now, pregnancy. Is pregnancy a condition, a disease condition? Homuseka, huye. Is pregnancy a disease or a condition, a debilitating condition?
No.
Huh? Somehow, because there are those skin conditions that occur when there is a pregnancy, okay? Because there is a slight decreasing of immunity. That's why some people may have problems, candidiasis, especially genital candidiasis, okay? Yes.
As Candida albicans, they are normal flora in some parts of the body, like skin or
No, never. When you have it, it's always a problem. That's why I said, if we discover there is someone who will ask again if Candida albicans is seen on the part, one of the part of the skin, is not a normal flora. I say no, it's always a problem. Of course, on the skin, it can stay for minutes because of the protection barrier we have seen. Okay, but when it goes to mucus, okay, on grounds, okay, mucus membrane, genital, then then you have a problem. Always, it's a problem. Then even in a child, if she has a female child, if she has genital candidiasis, always they think about sexual abuse. Okay, to be investigated. This is I take it as that. In adult, of course, it may be an STI, sexual transmitted infection. Okay. In females pregnancy, yes, it's common because the immunity has changed. Okay, and most of the female patients, they may like have genital candidiasis. I have seen many cases. And the other cause that may cause genital candidiasis, especially in non-circumcised male, yes. In Huye, all males are circumcised.
Yes.
No. Okay. Then I was just saying that in a non-circumcised male, candidiasis again may be a problem. Okay. Like in females, of course, and secondly, in females, the excessive hygiene on genital, on private parts, may cause the candidiasis. Okay, the vulvar vaginitis. Okay, then please, females, use with caution this medicated soap or this things for intimity to wash, to clean the area. It's not good. Use just the plain water. And don't go far. Okay. This is what I called for in male Candida Baronitis in non-circumcised people. In Candida vaginitis, of course, you have a creamy discharge and plus itching. And the vagina is red, is very erythematous, and if you don't treat, it becomes fissured, it becomes ulcerated. And at a long run, they have problems. Now, oral candidiasis on mouth, it's common in people who use for a long time of oral corticosteroid like prednisolone. It may be also, again, a risk factor. And you have what we call angular keratitis at the corners of the mouth. Okay. We may have again Candida intertriginous Candida at web space of in interdigital areas. Okay. Of course, erythema, cracking or fissures and maceration with soreness and pruritus. And this follow always these people who soak for repeatedly soak their hands in water, in cleaners, for example. It's a common. Investigations, most of the time, for me, I don't need any investigation. It is a clinical diagnosis. You have to just to look after creamy discharge or milk-like on the mouth. Okay. The tongue is charged with whitish plaque, and then treatment. We have meconiazole nitrates 2%. It's a vaginal cream application for 80 days to stop sexual intercourse, of course. We have what we call cotrimazole ovule, or you can take fluconazole, 100 milligram. They are capsules or tabs just for 2 weeks. Antifungal treatment, just clean this microorganism that is yeast infection. In mouth, you can use a nystatin, chew like 5 to 7 times per day, and then you swallow. You have a systemic treatment. We have said it, oral fluconazole, Impetigo candidiasis, keep dry, interdigital areas. You may use powder, antifungal powder, like meconiazole, etc., etc. Recommendation: candidiasis, vagina or baranitis, evaluate asymptomatic sexual partners because it is contagious. I consider this as a sexually transmitted infection, STI. If persistent, candidiasis lesion spread beyond the genitalia, consider the possibility of diabetes and acid form disease. Always, of course, when you have a non-obvious cause in candidiasis, always check for diabetes. Always. You see a healthy people, a healthy patient who is not on any treatment, developing genital or mouth mucosa candidiasis, always don't miss to check what? Diabetes. Now the slides is in tomorrow I will show you pictures of this. I think I have picked the one which I have not. Now, in a superficial fungal infection, I have just selected 2 types. Infection by yeast, which may lead to candidiasis, pityriasis versicolor, and seborrheic dermatitis. Okay, we have seen that seborrheic dermatitis affect the grazy areas mainly. Okay, which are the scalp, the nasolabial folds, and the upper trunk, if you want, and genitalia. Again, the groin areas. Okay. Now we going to candidiasis, which may be seen along together with immunosuppressed people, AIDS, or diabetes. The treatment is easier. We use antifungal, topical for localized lesions, and the fungal systemic for severe or mucus involvement. Okay. Now we go to the second type after yeast, dermatophytosis, and we have numerous fungal infection apart of this. That I have selected this because we have it in the routine consultation. Okay, this you will have definitely. You will see in Wakari and dermatophytosis. Now, dermatophytosis is a fungal infection often seen as tinea or termed as tinea or ringworm because it's seen as a coil with the clinical entities or forms, depending on the anatomic site and the etiologic agent involved. Okay? Types. When we have the scalp or the head involvement, the tinea or the dermatophytic infection is known as Tinea capitis. Capitis is head in Latin. Okay? Tinea corporis on the glabrous skin, hair is part of the body. We have seen, isn't it? Tinea corporis on the hairs region. Okay? Now, tinea cruris, grown areas covering the T of the genital area still behind. Sometimes you have on pubic area, and it goes behind in between two buttocks. Integrity, I think. Okay? Tinea pedis, feet. Okay? Tinea unguum or onychomycosis when nails are affected. Okay? And tinea barbae on when this area, the bird are involved. Okay? Sibyo. Ubutare murakurikira? Now,
Yes.
okay. Tinea capitis, the one that involves the head or scalp. We have 4 causative agents: microsporic tinea, trichophytic tinea, inflammatory tinea, and fevers. This one is caused by microsporum species. The one with the trichophyton species. This is just for you to describe. I don't think this is just for your knowledge. Because to have a microsporum canis, you have to go to the lab, culture, and then you identify. But clinically, you have large patches or plaque, hair fracture at a few millimeters above the surface of scalp, and no alopecia. You see, in trichophytic tinea, we have multiple small patches instead of one in microscopic tinea. And hair fracture at the scalp, giving a black dot aspect. Okay. Now, in inflammatory tinea, it's associated to inflammatory because this is very aggressive. It originates from the cattle. It is zoophilic. Now, feathers or fuzzies, yellow cap-shaped crust known as cotton. I think this is for description, but what we see, the one is a microsporum penis or spacey because the fracture at a few millimeters from the hair, but just you have patches here at just at the scalp. This is trichophytic. This is what I was saying. Small multiple patch, you see? Now, sometimes the problem of capitis is impetiginization. It is affected by staphylococcus. Okay? This is what we have seen previously. Non-impetiginized, non-bullous impetiginized. Okay? Because we have pre-existing tinea capitis, which is superinfected by staphylococcus, then this is non-bullous. Please mute your okay. The problem is that it leads to a definitive scar, alopecia scar. You see here. This is alopecia because the hair follicle were removed with these clusters. Okay, then the patient will grow up with this definitive alopecia. Uzajya ubona abantu bafite imisatsi mikeya kubera barwaye ibishikera birimo amashyi. Okay. Yes. Now we have here tinea corporis, tinea cruris, tinea pedis, tinea ungum. The causative agent here, let's border with central normal skin. Okay, all this you will have a ringworm. It's round, it is circular. Okay, it's easier to diagnose clinically, but in some patients you have acute tinea. This is tinea, not tinea. Tinea pedis with vesicles, pustules, etc. Look at this one. This is a good, you see, round, circular, centrifugate, or annular regions. Okay? This is characteristic for Tinea corporis. Okay? Round. Because it grows from here to outside because it eats keratins, dead cells. Okay? When here the dead cells at the upper layer of the epidermis, then it goes up to find all cells at the corneal sides. Here, rare, then it goes up. You will have some plaque which is large, even though or that covering the or trunk. Okay, and this one is contagious. Dermatophytic infection is contagious. Now, treatment, nikinza kibabaza. Topical treatment always associated to systemic treatment because many doctors fail to treat tinea capitis while it's prevalent in all rural areas, even in cities. Okay, the treatment is simple. Use glycyrrhizin. It's cheap and affordable. Okay, you may give 20 milligram kilo per day up to 6 weeks, 42 days at least. And the absorption of glycyrrhizin is facilitated by the fatty meal. That's why we recommend people that to take it with milk. Okay? Fluconazole, of course, or different, is an alternative as well. Okay, at 6 milligram per kilo per day. Please don't treat alone tinea capitis with topical treatment. Okay? Always associate with oral treatment, prisofirmin or fluconazole. Right? This is what? This it occurs at grown areas. Which form is type Tinea cris? Okay? Because it is here, it may go even up there. You see the borders well limited. The limitations are good here. It is annular one. Okay? This is Tinea cris. Okay? Now, in this one, this is a Tinea pedis, interdigital type. Ibimeme. Okay? Because of this jungle boots, we always put. Okay? In the morning, you don't have time to wash well your interdigital tools. You don't dry well, and then with the humidity, it favor fungal development, dermatophytic development. Okay?
Yes.
Yes. Which means always take time to clean and dry well this digital web space. Okay? Dore ko mushyiramo inkweto abihuyeho ntibibareba cyane. Okay? Ibimeme. Now, this is another type of an aggregated Tinea pedis. You have, or you may need to describe this type of region. What do you see? Huh? From Huye, can you describe this region? Hey,
It's a black like.
you may describe all of this one. It's whitish, okay? Wagira ngo yakandagiye mu ifu. When it is white like this one, these are scales, isn't it? I think some areas it form a thick plaque, okay? A thick plaque is hyperkeratotic. Look here, okay? It's mixed. Hyperkeratotic, scaling, plaque, okay? This type of Tinea pedis is moccasin type. Niko bayita. Moccasin. A moccasin is a type of shoes. Okay? Tinea pedis. Now, Tinea corporis treatment you may use when you have localized regions, topical treatment, antifungal treatment, and you may use grisophilin or other antifungal like fluconazole. Tinea pedis and Tinea manum. Tinea manum is the one involving the palms. Okay? Pedis involves the plantar areas, the soles, and it may just goes up to the dorsum, but always you see on the plantar area or soles. This one, cotrimazole cream for interdigital type, local treatment. But for systemic treatment, always use a systemic treatment or oral treatment like terbinafine. Okay? Terbinafine. Now, in the recommendation for Tinea capitis, avoid sharing combs, towels, and clothes. That's why it's contagious from one kid to another one. Tinea pedis, keep dry your feet. Wear open footwear if possible. Wear cotton socks if you need to be, because the nylon ones make more humidity. Okay, change socks daily. Muhindura amasogisi kangahe? How long do you take this in your socks? Are you sure? Or once a week? Who here? How often are you changing your socks?
2 days.
2 days. Just remember that changing socks daily is recommended to avoid this kind of tinea pedis. Okay? Now I think we are done with superficial fungal infection. If any question, please ask before we close the session, and you vacate for other activities. No question?
Question.
Yes.
Is it
Put
necessary
on
to
question.
is it an obligatory to treat tinea pedis using both topical treatment and systemic treatment at the same time?
No. You
Okay.
always use oral treatment. Like what we have terbinafine, 250 milligrams per day, 30 days. But for tinea corporis, other tineas may use topical and or oral combined. But even if you use topical, there is no problem. But for tinea pedis, always, because the epidermis at this area is thick, then there is no excretion of the antifungal property cannot reach the stratum corneum.
Okay. What about the clotrimazole cream? You have shown us as included.
Clotrimazole cream used for tinea corporis or candidiasis. There's no
Okay, thank
problem. Clotrimazole cream. ariyo bakunze kwita candid cream. Okay?
Yes, sir.
Muze gusoma iriya nuze kiriya gitabo. Reka nze buretse kugenda gato just for direction. Wait a bit, just are you still around?
Yes.
Yeah. Now, how to use this dermatology guidelines? It's the recent one we have developed that just may guide you through your further reading. It's simple to read it and summarized for the most of the skin condition seen in a district hospital or referral hospitals. You see, it has been out in March 2022. Now, you see the type of content. You have definition, contact dermatitis, atopic dermatitis, and other eczema and complication of eczema. It's concise and friendly to read. And when you go to bacteria, you have many sub-chapter covered. And you see you have also scabies, viral infection. Just we'll go through this topic tomorrow. Now, I think like tomorrow afternoon, I will cover STIs. It's a syndromic approach of how you diagnose and treat STIs syndromically. Okay. Maybe if you have time, we go to connective pigmentation disorder, vesicular bullous. If I don't have time, just you will read at your own time. Okay?
Yeah.
I think this will help you. Of course, we can go to HIV and AIDS skin disorder as well for tomorrow. Now, this is even you don't need the topics I have covered today because you have everything here, which is well elaborated. Okay? Okay. Okay,
Yes.
thank you very much for attendance. Then let's meet tomorrow at 8. I'll be a bit early to start. Okay?
Thank you, lecturer.
Bye.
Bye.